Good day, and thank you for the opportunity to present this proposed change in patient care delivery. This presentation focuses on interdisciplinary the transitional care program for adult medical surgical patients who are discharged home and are at risk for readmission. The purpose is to show why this change is needed, how it will work, what it will cost, and why it is realistic for organization. The proposal focuses on finance, quality, patient safety, patient experience, administrator level decision making. So each of those areas is addressed directly in the step. My goal is to present a clear, practical, and evidence-supported plan that can improve transitions of care and reduce avoidable 30-day readmissions. Why this change is needed? The background of this issue shows why this practice change matters. Readmissions within 30 days are a quality problem across countries, where an international average of about 32% in one OECD analysis. In the United States, about 1 in 5 Medicare beneficiaries are readmitted in 30 days, which has made readmission reduction a major quality and cost priority. At the local level, the project site reports that about 18% of adult medical surgical discharges are followed by an unplanned readmission within 30 days. This suggests a clear practice gap because current discharge work is not always timely, consistent, or well coordinated after patients leave the hospital. These are practical problems that can be improved through a standard transitional care process. In short, the problem is not just the readmission itself. The deeper issue is an unreliable transit from hospital to home, and that is the part of care delivery this project is designed to change. DPI Project Snapshot. This slide summarizes the DPI project itself. The project focuses on adult medical or surgical patients who are discharged from home from an urban safety net hospital in New York City. The accessible population is about 288 eligible discharges over an 8-week period, and the minimum planned sample is 165 patients. The comparison is current discharge and follow-up practice at the site, and the outcome is 30-day all-cause readmissions. The pilot is structured as a quality improvement project with a quasi-experimental pre- and post-comparison over an 8-week implementation period. The project is also guided by 2 important frameworks. Orem self-care deficit nursing theory supports this to strengthen patient ability to manage care after discharge. Lewin's change model guides implementation through unfreezing, moving, and rephrasing. Together, these frameworks support both the clinical logic and the organizational change process needed for a successful rollout. This snapshot shows that the project is clearly defined, feasible, and aligned with the current planning documents. Evidence from literature. Bailey et al. Described the SafeMed model, which raised 30-day readmissions by 31% and lowered medical expenditures in a high-need population. Pugh et al. Found that hospitals using more evidence-based transition processes had lower readmission rates, which supports a multi-component intervention rather than a single action. Hugh et al. Report 7.1% 30-day readmissions among program graduates compared with 14.9% among those who did not complete the program, along with lower costs. Ramon et al. Found that the care transition team was associated with readmissions dropping from 18% to 9% in the community hospital setting. Kim et al. Showed that timely transitional care management follow-up within 2 weeks was associated with lower readmission risk with a hazard ratio of 0.74 after propensity matching. Taken together, these 5 upload articles show that early contact medication review, coordinated follow-up, and structured team roles are practical strategies to improve outcomes and strengthen financial case for change. SWOT analysis. The SWOT analysis helps show both the promise of the intervention and the barriers that leaders from anticipation. Major strengths include strong evidence base, use of existing staff and electronic systems, and clear alignment with goals for quality, safety, patient experience, and value-based performance. Another strength is that the project budget is modest, which supports feasibility and future sustainment. Weaknesses include workflow variation across clinicians, limited time staff, and the challenge of reaching some patients quickly after discharge. Opportunities include lowering avoidable utilization, improving discharge consistency, and building a standard process that will later spread to other units. Threats include staff turnover, competing priorities, incomplete documentation, and difficulty sustaining follow-up when the review unit is busy. This SWOT analysis matters because it moves the discussion beyond whether the intervention works in theory. It shows what will help or hinder success in a real practice setting. By identifying these factors early, leaders can make a decision about support, resources, and sustainable planning. Proposed solution. The proposed solution is the implementation of an interdisciplinary social care program for adult medical and surgical patients who are discharged home and identified as high risk for readmission. The intervention begins before discharge and continues through early follow-up after discharge. Core steps include using a standard risk identification process, completing discharge teaching and medication reconciliation, arranging follow-up visits within 7 to 14 days, making follow-up contacts within 48 hours, and commanding nursing, provider, case management, pharmacy, and social work actions. Each step is documented in a consistent workflow so that the intervention can be achieved, delivered, reliably, and audited over time. This is not a complex technology project. It is a care delivery design that aims to make transition safer and more reliable. The evidence suggests that better outcomes come from combining several processes rather than relying on only one, such as phone call alone. For that reason, the proposed solution uses a multi-component structure that fits both the local need and the current evidence base. How the solution meets population needs. The solution meets the needs of the population because it targets exact points where patients and families often struggle after discharge. Patients need clear instructions, better medication understanding, early contact when problems begin, and faster connection to follow-up care. Families need a simple plan and reliable contact points so they know what to do if symptoms worsen. The care team needs a standard workflow, clear roles, and better communication across disciplines. Leaders and payers need lower avoidable utilization, stronger quality performance, and a cost-conscious strategy that can fit within daily operations. The proposed program addresses all of those needs because it organizes discharge work and post-discharge follow-up into one structured process rather than leaving key steps to chance. This all aligns with the payer review. Medicare, Medicaid, and managed care plans benefit when readmissions decrease because repeat hospital use is expensive and often preventable. In that sense, the intervention serves patients, staff, leaders, and payers at the same time, which is one reason it is a strong proposed change in patient care delivery. Cost, payer, and financial fit. The financial case for this complex was changed is favorable. The estimated total project cost is $30,150. Labor is the main cost at $12,880 because the project depends on staff time for planning, staff education, workflow organization, and limited data support. Materials are estimated at $150 and miscellaneous expenses are $20. Travel, equipment, space, and license costs are listed as zero because the project uses the current worksite, current electronic system, and current hospital space. This matters because leaders often ask whether a change is effective and affordable. Here, the answer is yes. The intervention relies on process redesign rather than expensive purchases. In addition, the support literature shows that transitional programs can reduce readmissions and lower episode costs, which strengthens the return on value argument. For Medicare, Medicaid, and managed care plans, fewer but affordable readmissions mean better quality and performance and lower utilization burden. This makes the project financially realistic and aligned with current and future healthcare financial priorities. Proposed change process. The proposed change process is organized into 3 simple phases that also align with Boon's model. The first is prepare or phasing. In this phase, the team reviews baseline readmission data, confirms role, financial the workflow, and educates staff on the purpose of the change. Second is launch or moving. In this phase, eligible patients are identified and surveillance sets are completed, and each section is documented in record and workflows. Third is sustain or rephrasing. In this phase, the team audits adherence, reviews readmission data, gives feedback, and turns the workflow into a routine part of the care delivery. This process is important because evidence-based change fails when staff do not know who is responsible, when to act, or how success will be monitored. A structured process reduces that risk. It also gives leaders a practical map for implementation rather than abstract recognition. By tying the process to both theory and site operation, the change becomes more manageable, measurable, and sustainable over time. Implementation and sustainability plan. This implementation and sustainability plan shows that the project is realistic in organization status. During weeks 1 and 2, the focus is on staff education, workflow finalization, and review of baseline data. During weeks 3 to 10, the information is piloted and monitored weekly. After the pilot, the plan shifts to monthly audits, refresher teaching, and data reviews so the workflow can be strengthened and sustained. The broader DNP timeline then continues into later project phases, including proposal work, approval, and implementation. Data collection, evaluation, and events and publication. Sustainability is built into the plan from the start. The program uses current staff, current documentation system, and current unit processes. It reduces the chance that it will fail because of resource burden. Sustainability also depends on feedback, measurement, and accountability. For that reason, the plan includes continued review of adherence and outcomes rather than ending after the first pilot. This makes the project more than a short trial. It creates a pathway for the new process to become routine practice if the results are favorable. Expected outcomes. Expected outcomes are both clinical and operational. The main expected outcome is a meaningful reduction in 30-day all-cause rate emissions compared with the current baseline. Additional expected outcomes include better medication understanding, faster follow-up after discharge, stronger coordination across inpatient and outpatient teams, and a less favorable workflow created by repeat readmissions. The process also expects to generate practical data that can guide decisions about sustainment and possible spread to other units. These outcomes are realistic because they match the exact mechanism described in evidence. When patients understand their medications, receive early follow-up, and know how to contact when problems appear, the chance of a preventable return to the hospital should decrease. Evidence base supports this expectation. Implications for quality, safety, experience, and finance. The implications of this proposed change are important across 4 areas. For quality, the intervention supports more reliable discharge and follow-up processes. For patient safety, it reduces gaps in medication understanding, missed warning signs, and breakdowns after patients return home. For patient experience, it can improve confidence, support, and trust during a stressful transition period. For finance, it offers a low-cost path to lower avoidable utilization and stronger value-based performance. These implications are realistic because the intervention changes care delivery at points where preventable failure often occurs. It does not depend on expensive equipment or new department. Instead, it improves how the current team organizes risk identification, education, follow-up, and creation. From a leadership perspective, this is the kind of practice change that supports present and future financing demands. Health systems are expected to improve quality and experience while controlling costs. The structured threshold care program addresses all 3 goals in one coordinated approach, which is why it is a strong patient care delivery proposal. This is the administrative feedback process summary, where I showed to my administrator at the hospital. So she mentioned that in terms of content track noted by the administrator, the presentation clearly explained the readmission problem, the need for structured casual care process, and the value of the proposed change for an urban safety net hospital. The financial discussion was practical, and the project was presented as realistic, low cost, and aligned with quality, safety, and patient experience growth. In terms of strengths and suggestions, the presentation was organized, easy to follow, and professional. The problem solution is to customer explain in simple terms. The administrator suggested placing even stronger emphasis on staff accountability, timely follow-up, and consistent communication across disciplines. Because success in a busy safety net hospital depends on reliable execution every time. In terms of revision, the minister recommended highlighting the urgency of reducing avoidable admissions, especially for vulnerable patients with complex medical and social needs. She also suggested reinforcing how nurses, providers, case managers, pharmacists, social workers, and leadership must all support a workflow for a change to succeed and be sustained. In terms of business support for sustainable next steps, the administrator expressed support for the proposed change and agreed that it addresses an important operational and patient care need. She encouraged continuous stakeholder engagement, regular outcome monitoring, and strong disciplinary teamwork to improve the chance of successful implementation and long-term sustainment. These are the reference. It brings together all the main sources to support the presentation. And last slide, this is the practice immersion hours completion statement. Thank you very much.